cesarean sections. And of course, any cesarean can shift from being routine to complex, so one always has to be prepared. And then to appreciate both the short and long-term complications of both cesarean and assisted vaginal birth and how to manage those complications. And in particular, how to achieve competency in obstetric anal sphincter injury repair. So in terms of monitoring and evaluation, we wanted to find out the engagement with the online components. So how well did people actually take it up? How satisfied were they with the training, and what was their level of achievement? So in terms of engagement, we looked first of all at the self-directed learning, those online recorded lectures and activities. % of the participants in our initial tranche completed 90% or more, and 2/3 of them completed all of the assignments. 6% completed less than half of it, sorry, more than half of it, but below 90%, and about 12% didn't really engage very well and did less than half of it. Somebody commented later, "I'm sorry, I didn't have the interest in doing the self-directed learning part initially, but now I'm enjoying and appreciating it. And I hope to complete the whole assignments by tomorrow morning." So they said that after they'd done the other components of the course. In terms of the time commitment, so did people think it took more time than they expected, or about the same as they expected? And about just over 40% thought that it was more time than they thought it would take them, so they thought they could do it more quickly than they could. Some of them watched the videos speeded up. There was this facility that you could speed up the lectures and go through them more quickly. So I don't know if we were speaking like little, you know, like how it is when you speed a thing up. But anyway, that's what they did to save a bit of time. So I hope they still learned from it. And then we went on to look at the engagement with the real-time virtual discussion groups. We had 60 initial participants, 90% of whom logged on for 4 or 5 out of the 5 sessions. It was very challenging to fully monitor the actual engagement through the sessions as participants dropped off and re-engaged. But you know what, as I'm standing here, and despite what Helen has requested, I can see people are looking at their phones and their laptops. So I don't know how engaged we are with face-to-face lectures sometimes either. So perhaps it's no worse with virtual, you know, sessions. So very challenging to monitor engagement when some people dropped in and out of the session. Somebody commented, well, face-to-face learning is good, but I find online discussions achieve the same. Maybe we just need to get used to it. And then engagement in terms of, were they distracted by their workplace? Because this was 2.5 hours a day, so people hadn't booked time off work. And you can see that about 3/4 of the people found it hard to get away from their workplace distractions to attend the sessions. Perhaps when you book a whole day off work and go somewhere else, it's easier. And then in terms of, did you get called away to an emergency case? And you can see again, more than half of them did. And that's why people perhaps were dropping in and out. And again, problems with internet connectivity. Now, the participants were given an allowance to buy internet time, but even so, just the standard of connectivity affected probably just over 1/3 of participants. In terms of the self-directed learning, listening to the recorded lectures, was it satisfying? Was it useful to their work? And the vast majority said it was either very useful or useful. And did they learn things that would make them consider changes to their practice? Virtually everybody thought that. In terms of the duration of the sessions, most people thought 2.5 hours was fine. And in terms of the group discussions, were they satisfied with the content? Everybody said yes, it was useful and relevant, and everybody said it would make them consider changes to their practice as a result. And in terms, finally, of the face-to-face sessions, again, everybody said they were relevant and useful, and everybody said they would consider changes to their practice. Specifically, we asked them about would they change their practice of assisted vaginal birth, and we do spend a lot longer on this course, giving people practice on mannequins for assisted vaginal birth as compared to the basic EMOC course, and everybody said yes, they would aim to increase their use of assisted vaginal birth, and they felt that their management of obstetric anal sphincter injury would improve following the course. So in the end, do they prefer face-to-face or online? So it depends when you ask them. If you ask them after the online, you get a greater proportion who say they'll prefer online, but when you do the face-to-face component, perhaps because it's more fun, it's the practical skills, it reverts to the majority saying they prefer face-to-face. So what did they think were the most important things they learned from this training? From the face-to-face training, assisted vaginal birth techniques, newborn resuscitation, obstetric anal sphincter injury repair techniques, techniques for managing difficult situations at cesarean section like the deeply impacted fetal head, maternal resuscitation and venous cut down. When we asked them overall what they would want to change in their clinical practice, the most common answers were increased use of assisted vaginal birth, consistent and thorough use of the WHO's safe surgical checklist in theatre, use of the maternity early obstetric warning system for picking up complications sooner, implementation of standards-based audit, and teaching others what they had learned. And then we went on to look at their achievements, and we measured that by pre- and post-test knowledge scores, and also OSCEs, which are objective structured clinical examinations. And we did 3 OSCEs. We did maternal airway management, newborn resuscitation, and assisted vaginal birth. And as is always the case, there was a greater improvement in the practical OSCE scores than in the knowledge. But there was a significant improvement in the knowledge as well. So you can see that in these results. What worries me is the low scores in these very commonly needed practical skills before the training. Yes, we improved a lot, but starting from a very low baseline. And here you can look at the breakdown of the different cadres that we taught. Most of the people on this initial course were medical officers, and this relates back to what we talked about yesterday, of sometimes the low level of knowledge and experience and skill of medical officers, and yet these doctors are the backbone of the service. So only 38% of them had good maternal airway skills, only 41% could resuscitate a baby properly, and only 42.5% could perform an assisted vaginal birth. The consultants were a little bit better. The residents, slightly better, but still starting from low baselines, and the interns, again, were very low baselines. So it just shows you how much input in these common necessary skills is needed to improve the quality of care and save lives across all cadres. So we need to input to medical students, residents, even consultants in some cases, and certainly medical officers. So, key points. It was hard to book time off work for short online sessions. It was hard to find time to do the self-directed learning, that 15 hours, when people were short-staffed. But nevertheless, learning did occur, and we proved that in our findings. And levels of satisfaction, I think you'll agree, were high with the training. It was a great advantage to be able to combine United Kingdom and Kenyan faculty together. The Kenyan faculty give us fantastic contextual awareness that some of the United Kingdom facilitators just don't have. So that was a real benefit. And there was a significant cost saving of $300 per participant. So I think that's very important that we take that into account, that blended learning saves money. There was, as I said, low pre-course skills scores across all cadres and all skills we tested, and that to me is a real concern. So in terms of our recommendations, blended learning has been shown to be effective, acceptable and cost efficient, and could be applied more widely to facilitate learning, and we have developed it now for other courses that we deliver from LSTM. Baseline results show that more extensive rollout of this training is sorely needed. And I really believe that continuing professional development should include mandatory clinical skills updates. Shouldn't just be a matter of you choose this course because you like the look of it or you get a better per diem or whatever. It should be that there is at least some element of mandatory training that's required by all medical practitioners. And perhaps repeated on a regular basis. So thanks to all the Kenyan and UK-based faculty, to the staff at LSTM Kenya for their great support, without whom we couldn't have done it, and to the facilities where we've been hosted, to Moi Teaching and Referral Hospital, Kemri, and the University of Nairobi for hosting us for the face-to-face sessions, and most of all, to our enthusiastic participants, and acknowledging our donors and partners. Thank you very much.
Thank you so much, Helen. Any question for her before we proceed? I'll pick only 2 questions at the end. Okay, so please just write down your question so that you don't forget. Let's have 1 more or 2 more presentations. Then we will pick all the questions at the same. Thank you. So we now welcome another presentation, that is EMOC mentorship package. Okay, maybe as we wait for Irene to project the slides, maybe for those of you who don't know me, I'm Helen Mutsi, Program Officer from Division of Reproductive and Maternal Health. So I'll be taking you through the EMOC mentorship package that was developed. Hope this thing is working. Okay, that was developed in conjunction with stakeholders, the county leadership, and the Ministry of Health. I'm sure you all know that we've been having EMOC trainings before, but the ministry has changed the EMOC trainings to EMOC mentorship. As I take you through, you'll be able to understand what is EMOC mentorship. The skills are still the same, but the approach is different. So globally, around 8-10 women die from childbirth. 99% of these deaths occur in low and middle income countries, of which Kenya is part of it. And according to KDHS 2014, maternal mortality is at 362 per 100,000 live births, or we can use the population census report of 2019 of maternal mortality being at 355 per 100,000 live births. So major causes of maternal mortality, we have PPH, infections, high blood pressure, that is preeclampsia, eclampsia, obstructed labor, and abortion complications. So 80% of these maternal mortalities occur due to third delay. What does third delay speaks about? It talks about the skill of the healthcare provider, there's things to do with supplies like uterotonics and other drugs and other non-pharmaceuticals. So in addition to EMOC skills, we should also be able to offer quality antenatal care. We should be able to embrace technologies such as point-of-care ultrasound. And the new guidelines are recommending at least 2 ultrasound. That is before 24 weeks and before 34 weeks of pregnancy. Then we should be able to have infection prevention and control in place, then do PMTCT, have family planning in place, be able to triage and do timely and appropriate referrals for our mothers. So there is an historical background of EMOC. EMOC has been there. The trainings have been there, but they were not standardized. Every partner or every stakeholder was coming with their different models of delivering EMOC trainings in the country that led in deficiencies in the knowledge, skills, and competencies of the healthcare providers. So in 2012, the Ministry of Health, in conjunction with stakeholders, and by then we didn't have counties, came together and came up with a standardized EMOC obstetric and newborn care curriculum. That was in 2012. So the trainings were being done in hotel setups. Skills labs were rarely available. And when trainings are being done in hotel setups, there are monies that are incurred. For example, training between 25 to 30 healthcare providers, it would cost the ministry or the partner that is supporting the training between 2.5 to 3 million, and it was not sustainable. And we rarely used to have skills labs. And for those of us who did the EMOC trainings, you can agree with me, within 5 days, you've been taken through a lot of skills, including post-abortal cares, how to collect blood samples. So somehow, by the time the 5th day is coming to an end, you can rarely remember anything. So the ministry, together with other stakeholders, saw the need of coming up with just an EMOC mentorship package that is facility-based. What do I mean by facility-based? We will have a mentor within the facility. We don't need to go and pick a mentor from facility A to come and mentor in facility B. Every facility that is doing a delivery, that is having a skilled birth, will have a mentor mentoring other mentees at any given time. So there was the issue of taking healthcare providers to hotels to train them. It is now a gone thing. It is facility-based. And every facility should have a skills lab. And so far, the previous EMOC trainings have been done in all the 47 counties, and about 20,000 healthcare providers have been trained in the on EMOC. But if you look at the maternal indicators, in terms of maternal and perinatal mortalities, there is a slight improvement. So the question is, what is the game changer? So is the EMOC mentorship going to be a game changer for the country so that we improve on maternal perinatal indicators? So the process and methods of coming up with the EMOC mentorship package, there was a roadmap to develop the package, consultative inception meetings by MOH and other stakeholders. We had several writers' workshop, we had a validation workshop, we did a pilot in counties, we had another workshop to incorporate what we had received from the pilot workshops. Then we had the launch on June 2022, and so far we've done trainings in 6 counties. So there are remaining 41 counties, and we will be doing some training in the next 2 weeks to around 22 counties. So if you have a look at that, was our launch on 7th June 2022, whereby the division, that is Division of Reproductive and Maternal Health, launched around 17 documents. That is in family planning, in maternal newborn health and adolescent sexual reproductive health. So what do I mean by a facility IMOC mentorship package? The mentor and the mentees are working in the same facility, the same unit. All facilities offering maternal and newborn care services are required to have a fully equipped skills lab, and whichever facility that is performing a skilled birth should have an IMOC champion and staffs undergoing mentorship. So the IMOC mentor should be hands-on, should be a person working within the maternity unit, not somebody maybe seated in an office somewhere within the facility, no. Whoever should be a mentor in a facility, an IMOC mentor should be hands-on in labor ward or in maternity unit. And this approach is deemed to be sustainable because there are no costs that are going to be incurred for taking healthcare providers to a hotel setting to train them maybe for 5 days. It is an ongoing process whereby the mentor has to assess, do a needs assessment to mentees. And if she finds that maybe the healthcare provider A has a challenge, maybe in pathographing, or maybe has the mentor, and a mentee C has a challenge, maybe in doing assisted vaginal birth, it is up to the mentor to organize with the mentees and be able to take them through the process. And after the mentee have undergone mentorship, there is certification for that. And every healthcare provider working in maternity unit will be the doctor, the obstetrician, or the nurse. They'll have to undergo certification every 2 years for their skills to remain relevant. So I think I've talked about that. So what are the 2 prerequisites to starting the facility-based mentorship within a facility? You need to have a fully functional skills lab and trained mentor, stroke champion from the maternity unit. And the minimum requirement of a skills lab, at least it should have mannequins, LCD projector, delivery bed, and consumable supplies. So mentorship structure, we have responsibilities of what the professionals at national level are supposed to do at the county level, at the sub-county level, and at the facility level. So those are the 4 structures of mentorship. So the mentorship approaches, we have one-on-one mentorship, group mentorship, e-learning / virtual mentorship, and reverse mentorship. But you will agree with me, it is somehow difficult to do a virtual mentorship in terms of skill. So it is up to the mentor and the mentee to agree which of these lessons should I take me as a mentee? Should I be able to do virtually or by e-learning? But when it comes to skills, it has to be a one-on-one approach. And what do I mean by reverse mentorship? You may find maybe your junior or your mentees are better maybe in something like maybe a skill. So the mentee, we're encouraging the mentor to be open, to accept even the mentees, to be able to take them through some things. And if I may just use an example, you find these young people, they are very good when it comes to things to do with computers or electronics. So the mentor should also be open to learn from the mentees. So what are our priority for IMOC mentorship? As a ministry, we need to cover all the 47 counties. As I said, we've already trained master TOTs for 6 counties. In the next 2 weeks, we will be doing training for around 22 counties. So the remaining around 18 counties, we need to source for funding and do trainings before the end of this financial year. Then we have structures in place to do monitoring and evaluation, so that we are able to monitor our M&H indicators. Yes, mentorship is in place. How are our M&H indicators? How are we managing our mothers in order to avert maternal, perinatal mortalities? How are our skilled deliveries? Then support for establishment of EMOC Skills Lab in health facilities. So as at national level, we want to start equipping the county referral hospitals with skills labs. Then from there, we now hand over to the counties to be able to cascade to up to the smaller facility. That is the level 2 that is doing a skilled delivery. So I think I'm done. So I acknowledge the MOH leadership, county health facilities leadership, and other stakeholders, LSTM being part of them. Okay, thank you.
Helen, who will take us through the health facility-based EMOC mentorships in Kenya. Thank you.
Thank you very much. You're going to be sick of the sound of my voice by lunchtime. When I was a child and I went to birthday parties, there was a certain game we used to play called Chinese Whispers. Do any of you know this game? So what you did, Fiona's nodding, she'll remember, you get everybody in a row, and the first person whispers a message into the next person's ear, and then that person to the next, and to the next, and to the next. And by the time you get to the end, you get the end person to say it out loud, and it makes everybody laugh, because it was nothing like the message that started out at the beginning. And I think this is a good image of what we need to avoid with mentorship. You know, we need the message that comes out at the end to be as clear and correct as the message that went in at the beginning. And to do that, and to impact our outcomes and have impact on improving maternal and newborn outcomes, you know, we need to mentor the mentors to make sure that the quality of the mentorship that they're able to deliver is such that what comes out at the end is as good as what went in at the beginning. So I just wanted to say that while I'm waiting for the slides to come up. And I'm just going to talk to you about some of the training and support for mentors that we've been doing in some of our counties. And in particular, throughout the time of COVID. Are we there? Almost. Okay. Not quite. Thank you very much. Oh, still nothing on the screen. Aha, there we go. Thank you. So outline the benefits and challenges of this mentorship program, what training and support we did, what the mentors have been doing, and a study of some of the mentors' views of of the support that we provided for them. And I've got a few quotes from some of the mentors. I want to start this talk and end this talk with quotes from mentors. Without mentorship, we only had the knowledge and the skills that we learnt that time, meaning when they did the EMOC training. There was no follow-up. So sometimes human beings are human beings. You end up forgetting what you learnt. And I think we've had adequate examples of that and why that matters this morning. So we've heard from Helen about the benefits of facility-based mentorship. Mentors are available all the time in the workplace, and that improves the access by the mentees. It can meet the need for refresher training. There's no added cost for travel or time away from the workplace for the mentors and the mentees. And there's potential for both one-to-one and group mentorship and alongside working. That's only possible if you've got enough staff to allow the mentor to take time to work alongside their mentee. Because they're in the same facility, it facilitates the building of relationships between the mentors and the mentees, because mentorship is about relationships. And it's building that trust and support between the mentor and mentee. And progress of the mentees is more easy to observe if you're in the same place. Challenges. It could be difficult if the mentor and the mentee don't get along well and they're in the same facility. And that, people are people, that can happen. In small facilities in particular, they're much as you would long to have a facility-based mentor in every facility, there may not be somebody with appropriate seniority and experience always for there to easily assume the role of a mentor. And it can be difficult to set time aside for mentorship due to the workload and workplace pressures. You need unfailing support from the facility in charge. And mentors themselves require training and updating to be effective. And I think, it will depend very much on the quality of the mentors and the mentoring experience they provide as to what impact it has. So mentors need to be mentored themselves. So what did we do to support facility-based mentors? So we had two components. First of all, we wanted to do some refresher training in basic EMOC skills, and then some specific training in mentorship techniques as well. And of course, this was delivered online, so how did we do that? So we had the self-directed learning component using some recorded lectures and some skills videos, and I fully acknowledge it's not as good as doing hand-to-hand, face-to-face skill training, but it was what we had to do at the time. And then we had facilitated online discussion groups with case studies focusing on EMOC decision-making skills and mentorship techniques. And I'm not ashamed to say again that making the right decision is just as important as doing the right skill properly. So in terms of when we implemented this, we had our first group of mentors going through the training in the middle of 2020, and then a further group of new mentors about 6 months later. So in terms of the EMOC refresher, we did 3 days of 2-hour sessions, and mentorship training was 2 days of 2-hour sessions. So as we've said, we prefer EMOC training to be very hands-on and practical. So can you do it online effectively? Well, Zoom helps. So what did we do? So we went through some of the main components of EMOC, shock and the unconscious patient, hemorrhage, sepsis, etc. You can see the full list there. And we had sessions on each of these components. And then the generic mentorship skills. And we looked at the attributes and skills of a mentor. We thought about how mentors can give feedback to their mentees, how they can help their mentees to reflect, how to formulate action plans when gaps have been discovered to fill those gaps, how to deal with the reluctant mentee, because some people are reluctant to have a mentor and to be a mentee, and how mentors can teaching techniques for mentors. So each session had a script, so you won't be able to read this, but this is just one example. Basically, the leader was telling the story, the case story, and then asking questions of the small group. And the people who were the learners were, you can see in red, that was the answers that the facilitator was trying to extract from the learner. And so all the scenarios were structured like this to lead to a sort of full discussion. And here we are doing different small groups with some improvisation on the part of some of the trainers. We had some videos. So LSTM, we've made several skills-based videos, vacuum delivery being one of them. So we played those. And so what were the challenges and the opportunities and advantages to this approach? Again, as I've mentioned before, there were issues with internet connectivity, and the cost of airtime has to be considered. People do concentrate differently online, so we had to tailor the duration. We had to factor in some breaks because nobody can concentrate for 2 solid hours online. We had this issue of, are they really there? You know, sometimes people, they have their cameras off on the Zoom because it saves bandwidth and it's easier to connect without the camera on. And then they would have their microphones on mute, which is necessary to avoid all the background noise interfering unless they're asked to unmute for a question. But sometimes if you're a facilitator and you're teaching online and you can't see that they're there, and their microphone's mute, and then you ask them a question and you get no answer, you think, well, have they gone off? Have they gone off to do something else? Have they gone to cook the dinner or deliver a baby, or do they just not want to answer because they're embarrassed and they don't know the answer? So that can be a struggle. And also timing-wise, you need to think, well, how long do you wait to give them a chance to think of the answer before you move on and ask another participant? So there are some specific skills to teaching online that we all had to learn. And I think building rapport is not quite as easy as when you're face-to-face, but it's possible. We were teaching through different time zones, so we have either a 2 or a 3 hour time difference with Kenya, depending on the time of year. And so sometimes we have to get up very early in the morning to teach people at 9 o'clock in the morning in Kenya. But that's okay, it's good for us. And teaching skills remotely can be more challenging. And we were also faced, as Fiona mentioned this morning, with a coinciding health workers' strike, which meant some adaptations. But the opportunities and advantages were there. We could reach people in multiple locations simultaneously, and that's a great thing to be able to do. So the participants and the faculty didn't have to travel, and that saves time, and it's also very good for climate change. And we've thought a bit about the importance of climate change, haven't we, in the last couple of days? So not flying or not taking unnecessary car journeys is very good for the planet. The sessions were short and perhaps less disruptive to clinical work because of that, and there was a focus on those key decision-making skills. We've been joined at times by other organizations, which has been great. The materials that are there, the recorded lectures are on YouTube and Vimeo, and things can be the videos, and so they can be shared with colleagues, and the mentors could later on use them when they ran teaching sessions. So sorry, this slide will be difficult to see, but in terms of feedback, we had strong agreements that the EMOC refresher training was a good use of their time and that they thought the training should continue. The majority agreed it was as useful as face-to-face training and that the case studies were a good way to learn. 86% agreed the training would improve the quality of their mentorship, and the same number that it had increased their confidence as mentors. 93% agreed they had learnt new mentorship techniques, and the same number that case studies were a good way to learn. 78% of them had accessed the lectures on YouTube. Pity it wasn't 100%, but still quite a lot. But again, we had some difficulty with internet-related problems for just over 40%. So we went on to do a little bit of qualitative research with selected mentors to find out their thinking a few months later. And so we had nurse midwives with clinical responsibilities. We had 11 that we interviewed. Somebody with a more administrative role. There was one, a clinical officer, a consultant, obstetrician, and a medical superintendent. So we interviewed 18. And of those 18, the number of mentees they were responsible for varied from 4 up to 17. Very difficult to have to mentor as many as 17 mentees, I would say. 12 out of the 18 reported that they were conducting monthly group mentorship sessions. 3 of them reported that they were doing it fortnightly. On the other hand, 3 were unable to specify or were doing it irregularly. And 12 of them reported conducting, in addition to group mentorship on a one-to-one basis. We asked them about aspects of the mentorship training that they had used. Somebody said, well, we learnt about reflection and self-reflection, and I was able to apply it. It came to life after the training. Using the Gibbs reflective cycle summarizes everything, and by the end, we have an action plan to follow up. So that was one of our nurse midwife mentors. Another one said, well, mentees like the feedback sandwich because it starts with what went well before identifying faults. Another said, feedback used to be only negative, and I missed out the positive part, but now I include the positives. And somebody else said, the training gave me a good way to handle feedback. Now the colleague may take it in a good way. And I think this was a recurrent theme, that learning how to give good feedback to your mentees is key to their engagement and their appreciation of the mentorship relationship. And it's not about criticism, it's about noticing what they're doing well and complimenting on that before moving on to say, and to improve, you could then do this. And then closing with something positive. That's the classical mentorship feedback sandwich. And I think above all else, our mentors really appreciated learning that technique. Use of the recorded lectures. So 12 of them had listened both before and after the training. Another 3 had listened, but only before. 3 of them hadn't really listened. 6 of them had gone on to share those lectures with mentees, and they are there to this day on YouTube, and I can give you a link if anybody wants to find it. And 4 had used them specifically in the teaching sessions. More of them said they would like to, but they didn't have access to functional projection for their training sessions. And as Helen said, that's a key component of being able to do facility-based mentorship in your skills area, is to have projection possibilities. So the challenges, several of the mentors reported that they really had trouble getting the models for skills training, and they lacked funds for transport of this equipment. I mean, this was particularly so in a widespread county like Garissa. Somebody said from there we had to request the mannequins from 110 kilometers away, which is not really very feasible. Many of the mentors struggled with getting opportunities for one-to-one mentorship. One manager said, well, I don't do it because I'm not a clinician. I would question whether that person really should have been selected to be a mentor. And as Helen said, and I agree with her entirely, mentors should be people who are hands-on clinicians on the labour ward themselves. Somebody else said, there are several people who would need one-to-one, but I haven't done it yet as I would wish. And I think that reflects the time, and the staffing levels. And, for the mentor to be freed up to do one-to-one mentorship in the clinical environment, you need to have enough staff on duty to look after the rest of the patients. And the frequency of the sessions, well, I would want to take I didn't like teaching, but now I love it, and it improves the service delivery. And finally, and really importantly, I can see a great improvement in how mentees manage emergency situations. Isn't that great? Another mentor said, well, you can see the indicators have improved, and that motivates me. So very satisfying. Somebody else, the number of referrals has reduced because we can manage PPH without having to make a 300-kilometer referral. We have implemented the early warning scoring chart. The team really appreciate it. A very simple way to monitor mothers. Now we are more confident to give magnesium before we refer. Somebody else, there were no perinatal deaths for 3 months. And somebody else, decision-making has improved. People can evaluate and put things in order. Previously, people could not make a decision. One of the consultants' mentors said, since the training, I enjoy the mentorship sessions more. Sessions are more friendly, so mentees are relaxed and they gain more. I give feedback in a more friendly manner, so mentees are grateful instead of feeling intimidated. And that's so important, isn't it? that we don't make the mentees feel intimidated. I think the old-fashioned supervision was much more intimidatory, and this is a whole new way of looking at things. So we conducted some follow-up visits to some of the facilities where these mentors worked, and the follow-up visits were very appreciated, and they provided encouragement to the mentors and the mentees alike. It allowed us to demonstrate face-to-face some alternative teaching methods and provided a fact-finding opportunity for the technical team regarding the successes and challenges, which was quite revealing. So in summary, mentorship seems to work best when mentors are hands-on clinicians in almost all cases. There are challenges in delivering one-to-one mentorship, but these challenges can be overcome. Mentors and mentees alike need encouragement to think beyond thinking of mentorship as simply teaching. Mentorship is much more relational than just a teaching session. Overall, many reported benefits to both mentors and mentees alike. And I would say that mentors need mentorship themselves. So any mentorship structure needs to allow for provision of mentorship for the mentors. Thank you. And I want to give the last word, as I did at the beginning, to one of our midwife mentors. She said, I remember some times back, I really hated working in maternity. I never liked it. I would say mentorship has really changed me. It's made me embrace midwifery. There is a time I felt like midwifery was not a part of me. And I was approached by the hospital to be the maternity in charge. I refused at the beginning. And after the mentorship, I felt like, yes, I can take this role. I can be the best midwife. I can mentor my fellow colleagues. So thank you to all the mentors and mentees who took part in this study, to those who gave their time to be interviewed in particular, to Martin and Gillian Smith for help with the interviews and the transcription of those interviews, and acknowledging all our partners and donors again. Thank you very much.
Let's have Helen MOH. Thank you very much, Helen and Helen. The unique combination, the same names. So anybody who has a question? I think I'll start from behind.
Thank you. And thanks, Helen and Helen. Those were great presentations. So mine is just to get us reflecting, because you showed very good data on the cost savings from the learning event. So even as the county has been discussing, have we seen any progress in terms of models where some counties have committed, to some cost sharing? We know, of course, that was happening before, but what's happening moving forward? And then to your point about people also having multiple tasks during the online trainings, have you thought about maybe having a YouTube channel where people can refer to the videos after? Because obviously we've seen the challenges of staffing. So is it realistic to have very long trainings when you know you may not get maximum attention in that time? And then thirdly, for mentorship, have you done any kind of maybe post-assessments just to see, like even among those who didn't want to be mentors, how has the response been after, once they did the training on mentorship? Thanks.
Thank you. And if you're asking a question, kindly tell us who you are. Thank you.
Hi, everyone. Thank you, Helen and Helen. My name is Emily from Perth. My question is to Mutsi specifically. Great effort with the mentorship, especially with the counties. I think that's the way to go. But I'm just wondering, we have a RAMCA scorecard now, and one of the ways that we can build a case for such mentorship is to show that the trainings have actually led to reduction in certain indicators for maternal and newborn. Has there been any effort to have this reflected in the scorecard to show that, this number of counties were EMOC trained, and this has led to reduction in maternal mortality. Because we have to show that it's working, it's reducing mortality, it's helping healthcare workers to be more equipped with skills. And I think the other question I had was on funding for the skills labs. You had mentioned that all the facilities that will be trained need skills labs. Has there been any contribution from the counties, or this is mostly MOH and partner-led? Just for a bit of ownership at the county level. Thank you.
Thank you. Peter?
Yeah, so thank you very much for the presentation. I think one of my first questions was on the first presentation from Helen, senior. I saw that most of the participants were high-level medical officers, consultants. Are you considering also the other cadres? Because I think even if it's theater, you need also nurses and everyone else for that kind of training. And secondly, again, just to follow up on Emily's, just to reflect on what Akacho also has talked about, what are the most sensitive indicators for us to measure mentorship? Rather than the numbers, or let's say like you have skills on this and this, or qualitative assessments, would we rather, let's say, for example, I saw in some areas where we did the mentorship, for example, comparing, let's say, like the 6 counties Helen was talking about, can we see any performance, better performance in those 6 counties where the mentorships have been rolled out? What are those sensitive indicators we can be able to measure for mentorship? I think that's what I'm just thinking about. Thank you.
Thank you very much. My name is Kashi from Hera. There are still a lot of classroom trainings being done. And I hear, from many sides, the classroom trainings are kind of outdated. Then there's obviously the classroom trainings which are focusing on TOTs. Then there's the TOTs with follow-up at the facility, which may start to become a little bit more like mentorships. Then the virtual learning, there's the blended learning. My question is, Helen, you mentioned the cost savings of $300 per person, and other Helen mentioned the costs of a classroom training. Yeah, I just wonder if there's been any study done on the effectiveness, the cost effectiveness, and possibly also the potential harm done by taking people away from their work, and to kind of compare between the different modalities of trying to convey knowledge and train on what's most effective, cost effective, and least harmful. Thank you.
Thank you.
Thank you very much for those beautiful presentations. First, I have a question about the choice of people you train, because sometimes it has been shown worldwide that sometimes somebody may be well trained, but does not have the correct attitude to implement whatever they've been taught. So how do you choose the people you train? Because you may be training them just to tick a box. That's one. Number 2, you had alluded to, and I heard it yesterday, about certification of the people working in maternity. I was just wondering how you are going to blend this with the requirements of the other bodies. For example, the KMPDC, whereby a doctor is licensed based on the CPD points. So is this going to be blended, or it is just going to be another certification? And if it is going to be another certification, then why the discrimination of OPSGYN and not other specialties? Thank you.
Dr. Akech, you didn't introduce yourself. Thank you. Anyone else? So we'll take on that. Irene.
Thank you so much for the presentation, Helen and Helen. It's always a pleasure to learn from you. So my question goes to MOH, Helen. It's good to hear that you are now targeting rolling out the EMOC mentorship to all the 47 counties. And you have also mentioned, and I totally agree, that the prerequisite for a health facility to conduct an effective mentorship, they should have a fully functional skills lab and the mentor, of course, trained mentor. So what would you do about the skills lab? Because when we are in the field, they are almost not existing in the facilities. And this equipment is really necessary because participants will tell you that there's no difference between a CME and a mentorship if there are no equipment and you're doing a skills topic. So what are your plans in equipping facilities? Thanks.
Thank you, Helen. Will answer that question. I don't want to enter into that, but I could have said something.
Yes, my question is for both Helen. You've done this capacity building in the counties, but now the ground there is a bit different because of political interference and also the issues of transfers of staff. You'll have trained a staff in a certain facility on this. You've capacity built that staff to handle these issues for the purpose of that service delivery. But after some days, because of changes in leadership, like the recent changes where we have new governor, we have new CC in place, new chief officers, and the main thing they start with is the transferring of staff. Somehow, when these people come, they want to work with new staff, new faces. And that transfer is done from the headquarters up to the lowest level. So from your offices, what have you done to sensitize these people that maybe through the Council of Governors, so that they know the importance of retaining those staffs in those facilities?
Thank you very much for your questions. Remember yesterday we really talked about retention in counties, but maybe Helen will talk something about the same, because yesterday the discussion was really up to date about retention in facilities. Thank you.
Okay, thank you so much for your questions. I'll start from the back. Tackling your transfer issue, I know it is a thorn in flesh. Every system that comes in on board wants to have new staffs. And when it comes to maternal and newborn health, you find generally even healthcare providers, they do not like working in maternity units. They view working in maternity unit as a punishment. So how do we handle this? I think we have, I don't know whether can I say it is a policy or what, but it depends on whichever facility. For example, if I may give an example, I used to work in Bagathi. Every 3 years, we used to have within transfers within the hospital, but I'm told some counties have 2 years, others have 1 year. So that's why the ministry saw the need to go the mentorship way. Remember, mentorship is an ongoing process. At any given time, whether transfers have been done or not, we should have a mentor within the maternity unit, because retaining healthcare providers sometimes in maternity unit becomes a challenge. Apart from maybe an obstetrician who has specialized in obstetrics and gyna. For them, we will not have any problem or a challenge to do with that. I'm sure maybe we have, within ourselves, we have some obstetricians. But maybe for the nurses, the clinicians, and the doctors, we might have a challenge in terms of retention. And also we brought to the need of the managers, we need to have retention of healthcare providers within the whichever ward or maternity unit for at least 2 years. And I know it is being practiced in some counties, but in some counties it is not. And mostly it is just politics. When a new officer or manager works in the office, they want to come with new people, and such kind of things are happening. But as a ministry, we are still championing for retention of skills in especially maternity units. So that's why we are going the EMOC mentorship way. Remember, it's an ongoing process. It's not a one thing, then you stop. This is because, assume you are my mentor, I'm a mentee. You'll have to be assessing me, doing a needs assessment on regular basis to check, am I able to do a certain skill? You'll find a skill like shoulder dystocia, because it is a rare thing. Mostly healthcare providers tend to forget about it. So what is the way? What is the game changer for this? It's just about mentorship. And if I'm undergoing mentorship, you don't need to call me from home for me to come for mentorship. You just need to, me as the mentor and you as the mentee, we organize in between ourselves. When am I when the workload within maternity is a bit low, then we work just in the skills lab, and the skills lab should be within the maternity unit. You take me through certain procedures, and if you've seen that I've mastered the skill, just take me to the real patient. That one is also allowed, because if you walk around the maternity unit within the country, you find most of the healthcare providers are students who've just been posted from KMTC and universities. Why? People assume they are energetic, they don't have any issues to do with a back problem, so they're in a position to carry on the load within the maternity unit. But when you ask them even, how do you dilute magnesium sulfate, they even don't know. So that one becomes a challenge. These skills, the EMOC mentorship skills, generally they've even forgotten. Or even if they were taught in KMTC, we've even incorporated, the ministry has incorporated EMOC training in pre-service, both at KMTC and universities. So that by the time they are coming out, at least they have that skill. But how are you going to retain this skill? It is through mentorship. So mentorship is an ongoing process. Hope I've answered. Okay, then another thing was a prerequisite for all maternities doing a skill delivery to have a skills lab in place. So as a ministry, I know this is a huge task. So the ministry has started with equipping county referral hospitals. And when the counties are doing their budgets, we've encouraged them to do budgets for at least the RAMCA budget. They have a RAMCA budget in place, whereby equipment will have to feature in, because we want sustainability. Because if we have to depend on a donor or a partner, it is not going to be sustainable. The donor will come in, do some few trainings, or buy some few equipment. What happens to other facilities? Because generally in Kenya, we have above 6,000 facilities doing a skilled birth. That is from level 2 up to level 6. So the ministry has started with the county referral hospitals, and we have support from UNFPA and UNICEF that has given the ministry some equipment, and we are encouraging the counties to have a budget for EMOC skills equipment, and also to come up with a skills lab. We are not saying they come up with a whole building, because if we say that a whole building for a skills lab, sometimes it is not visible. But for a county that is in a position to do that, there is nothing wrong. But if they can just pick a room within the maternity unit, or just come up with something like, we call them boards, then they separate, they do just like a room, and put there the skills equipment like mannequins, LCDs, and the consumables. it is good for us to go. So the counties have to cascade it up to level 2. That is dispensaries where a skilled bath is being performed. So hope we will reach there. It is a huge task, but we are starting small, but we believe we are going to grow big and escalate. Then there was a question on certification. Yes, when you undergo this training for EMOC mentorship, because remember we are having 11 modules for this, and it is for master TOTs, we take them through in 5 days, but for EMOC training within the facilities, it is up to 3 months until the mentee masters the skill. Then they are certified. They are entitled to get their CPD points when they take them to, for example, the Nursing Council, the Clinical Officers Council, and your Doctors Council, that big long name. You are entitled for certification, for your CPD points. Then there was a question on choice of people to be trained. Yes, we will be training the clinical officers, nurses, and doctors and obs-gynas working in maternity unit. And maybe I might have gotten your question well or not. Generally, we see healthcare providers viewing going to maternity. Maybe if I'm posted to maternity, they view it maybe as a punishment. So it is just through mentorship, you are able to change their perspective, their attitude toward appreciating working in maternity. And as I said earlier, every hospital should have structures on how long somebody should be retained in a particular place. For example, I'm a nurse by profession. I can work in whichever ward, but which structures should also be in place? I, as an in charge, when I'm doing transfers within the facility, what should I be able to consider? Do we have a mentor in place to take the other mentees or other healthcare providers who are coming on board on mentorship? Because you cannot just do transfers. You wake up in the morning and you transfer everybody in maternity unit. You bring in other new staffs. Even if it's a medical ward, you need to have people, healthcare providers being retained there who can orient others. So that's why the ministry went to the aspect of mentorship in order to have some retention of skills in maternity. Then indicators to measure on mentorship, we have structures, our implementation plan. So we will be able to monitor our maternal indicators. We'll be monitoring things to do with skilled birth. Generally, as a nation, we are doing very well in terms of skilled births. We no longer call them deliveries. We say skilled births. We will be monitoring things to do with the maternal mortalities. If you look at the studies, for example, the CMDs, the Confidential Inquiry into Maternal Deaths, and PDSR report, most of our mothers, 80% of our mothers, are dying because of the third delay. And what does third delay entail? It entails the skill of the healthcare provider. It entails things to do with supplies within the hospital. It entails things to do with the referrals, timings of referrals. So in terms of skills, the ministry has been able to handle these, and we hope it is going to be a game changer by having a mentorship structure in place. So that is, we've just started rolling it out, but we have structures in place whereby we are doing monitoring and evaluation, whereby we look at how are the MNH indicators performing. For example, if I have a look, I'm at the county level or at the national level, then health facility B has a challenge. They are coming up with high maternal mortalities, high perinatal mortalities. As managers, we are supposed to move to that health facility and try to find out what is the problem. Is the problem to do with the skill of the healthcare provider? Is the problem to do with the supplies? Is the problem to do with maybe letter referrals? And be able to mentor, be able to support that health facility in order for it to avert such bad indicators. Then funding. There was a question on funding, how sustainable this program is. As I said earlier, we've encouraged the counties when they are doing their budgets for RAMCA, they be able to include equipment for skills labs and also trainings for the EMOC trade. They be able to have structures in place whereby as a county they are supposed to monitor EMOC mentorship processes. If you looked at our EMOC mentorship structure, we have at national level, so we have our tasks at national level. What are we supposed to be doing in order to support the EMOC mentorship? At county level, what are their roles? At sub-county level and also at the facility level. So those structures are well laid and everyone understands their task. As I said earlier, we've trained 6 counties and they are continuing with their mentorship, and we will be doing in the next 2 weeks, 2 more TOT training for EMOC. Then the remaining counties we are also sourcing for funding so that we also bring them on board, but we will be monitoring the RAMCA indicators. I think I managed to answer all the questions. Thank you.
Thank you, Helen. Somebody asked about were the lectures and so on available on YouTube. If you look at Helen at LSTM Maternal Health, you will find all the EMOC lectures that we provided for these mentors and all the generic mentorship lectures as well for the self-directed learning. So that's Helen at LSTM Maternal Health. They're still there. And the advanced course is all available through the WCEA website. That's the World Continuing Education Alliance. In terms of the indicators, I would challenge you all to say it's not just about morbidity, and it's not even just about morbidity and mortality, it's about the quality of the patient experience as well. And when we're assessing quality of care provision after any intervention, training or whatever, we should also take into account the quality of the patient experience and not just did they die or live. I think we should look at indicators, but for any one facility, looking at maternal mortality may not be terribly useful because, you know, we're talking about numbers of deaths in hundreds of thousands, and we don't have any facility doing hundreds of thousands of deliveries. So you may not, over a shorter period of time, see much change if you look at the individual facility level. So we have to find other things to measure. Looking at perinatal mortality is a bit more sensitive because sadly babies die more often than mothers do. But we should expand our horizons when we're thinking about indicators and indicators of quality of care, and think about the patient experience as well through, you know, patient surveys and interviews and so on. About the advanced course and what cadres can join, anybody. So when we set it up, when it was face-to-face, we had different cadres weaving in and out. So we had a day that included the senior midwives from the labour ward, and then we had a day that included the senior theatre nurses. We had several days that included anaesthetists, and we had one day that was specific for obstetricians, and the anaesthetist went off with an anaesthetic trainer and did specific anesthetic things as well. So it was quite fluid. It was much more difficult to do that when we had to go to the blended learning in the constraints of COVID and so on. And I would say I do thoroughly believe in multidisciplinary training. We work together, so we should train together. I think that goes without saying. We had limited funds, extremely limited funds to pilot these courses, and you know, there was never a specific budget just for the advanced course, so we kind of did it on a shoestring. And it's not that we didn't want to include other cadres, but we were constrained, particularly when we went to blended learning. And also the anaesthetists, sadly at the time of COVID, the anaesthetists were very busy running intensive care units and putting lots of people on ventilators with COVID. So we lacked our anaesthetic trainers throughout the period of the intense COVID outbreak when we were doing quite a bit of this training. So we had to drop the anaesthetic multidisciplinary aspect for that reason. It was just pragmatic. It's not that we wouldn't want to re-include them, and we would if we get more funding. I would certainly want to go back to making it much more multidisciplinary. But there were some aspects that were not useful for all cadres. So, you know, for a labour ward midwife, it might be interesting for her to learn how to do a complex caesarean section, but she's never going to be doing it. But it's very pertinent for her to learn about decision-making on the labour ward and prioritisation and preparation for theatre and so on. So there are aspects that are more relevant to certain cadres. I think I've addressed the issue about indicators and using standards-based audit to measure changes in, not maybe indicators, but in terms of outcomes, you know, how many patients do we use an early warning scoring chart for example? How many patients do we use a WHO safe surgical checklist for? We know the safe surgical checklist saves so many lives. You know, the 40% decrease in mortality overall in the studies looking at the WHO safe surgical checklist. If you had a drug that could save 40% more people, you'd make a fortune. This is a piece of paper that can do that. So we can look at things like that to monitor our outcomes. In terms of the question about taking people away from work and the harms that may do, I would say that by doing mentorship and short, more frequent trainings, you don't need to go on a whole course to do all these things. You can do it bit by bit by bit, and that's what mentorship should do. It should do a different aspect, either weekly, fortnightly, monthly, for an hour or 2 hours, and you're taking people a lot less out of the workplace by doing that, and you're doing it on site as well. So I would say that you do less harm by doing that. But we know that by not training and not providing mentorship, harms happen. There's no doubt about that. So we ought to think hard about doing this. In terms of are we measuring it, we've got another course about antenatal and postnatal care that is there's studies going on comparing doing it with blended learning as compared to entirely face-to-face. So we are actively working on measuring differences, not on our advanced course because we don't have funding, but for the antenatal postnatal care course.
just a concern. Is the government is in plan, maybe the county government or the national government, to introduce a certain package, especially for the nurses working in maternity, at least to encourage them so that how is it talk maternity? A certain package.
Okay, a package in terms of incentives, in terms of trainings, or what do you mean by a package?
So I mean, maybe a certain package, maybe in the salary, in terms of salary.
Okay.
For me, I think I
Karen, you
would
can
say it
answer
is
that.
solely on county government, because this is not a national government issue. If it's about retention in maternity because of skills, or I think it's supposed to be within the frameworks of employment within the county. Motivation, there are so many ways of motivating healthcare providers in whichever jurisdiction they are working in. Sometimes it is because some give, yesterday we heard of mandazi and tea that motivate nurses to attend CMEs. It was a heated discussion yesterday. Apparently research shows that they attend CMEs because of tea and mandazi. Just as simple as that. Another one is just recognizing the healthcare providers who are performing very well in maternity as giving them this recognition and having their pictures framed in maternity as employee of the month in maternity. I've seen that work in some facilities. I've also seen that work at the end of the year. They are appreciated probably with a token or something. I have seen that work in some facilities. But when it comes to a package, probably for me, I don't think there's any specific package that will be able to be given for healthcare providers to be retained in maternity, but motivational ways of remunerating nurses or healthcare providers who are doing good job in maternity. There are so many ways of doing that.
Okay, maybe just to add on what Karen has said, as a ministry, we appreciate maternity has a lot of workload. And that's the way she says, we have so many ways of motivating our healthcare providers who are working in maternity. And if I, for example, allow me to use a county like Nakuru, if you undergo the reproductive health training, tunaitanga DTC. I know we still have, we had 8 DTCs, but only 5 are functional. And they're struggling with having students. But if you go to a place like Nakuru, they are ever having students, because once they've graduated, there's a way the county recognizes them. It picks them as sub-county RH coordinator, or it just gives them a task within RAMCA. So maybe you can have, it will now be county specific. They look for ways of even motivating these healthcare providers, even to go for those DTC courses, or this mentorship, taking them the mentorship courses within the maternity, and just see a way of how can we motivate these healthcare providers now that they've worked on our maternal newborn health indicators. If we had high maternal mortalities, they've been able to be reduced to a certain level, or maybe stillbirth, macerated or fresh stillbirth, whatever, or even an increase in ANC attendance. So the county government should be, because remember health is also devolved, should be able to come up with modalities to be able to motivate these healthcare providers for them even to be retained in there working within the maternity. But otherwise we appreciate, and we know working in maternity, it is not a joke. So I normally see some facilities, they have teas, they have lunches, so I don't know where you are coming from in Garissa. Director alikuwa hapa kutoka Garissa County, step out. I don't know how you motivate your healthcare workers working within the maternity.
Can I just address this issue slightly more philosophically? When it comes to motivation, we have both intrinsic and extrinsic motivation. Extrinsic motivation is about sticks and carrots. It's not about what you do inside yourself, it's about what other people do. So you're asking a bit about carrots there. So yeah, extrinsic motivation may come in all sorts of forms, maybe financial or other, as Helen has said. Intrinsic motivation is how you feel in your heart about the job you do and the satisfaction that you get from having done a good job. And I'm sure, you know, we all want to put bread on the table for our families, but equally we want to go home from work feeling that we've done a great job. And that motivates us. And you could see from some of those quotes I read you how that does motivate people. And the way to help people to go home from work feeling they've done a great job is to train them well and to support them well by mentorship. So I think it's down to us to provide that training and mentorship to help people to know that they've done a good job. And when the mother turns around and thanks you for the safe birth of her baby, that is a fantastic motivation, and it makes you feel good inside. And, you know, I loved my job as an obstetrician. I did it for 35 years. My colleagues who were dermatologists slept in bed all night and got paid the same money as I did. But I wouldn't have gone and been a dermatologist for all the tea in China because I loved what I did. And I hope that we can be motivated from our hearts because we love what we do. We've been well trained and well supported in what we do. Thank you.
It's just a clarification from Helen. In terms of skills lab, I would have loved to hear the exact cost for maybe one skills club and looking at how much we are looking at. And for the first 6 counties that you already trained, where are we in the commitment to setting up skills lab and maybe even having a single one? And I'm mentioning this as from Jacaranda, where we've done a number of EMOC mentorships. And even as we are looking at the AVB, like the challenge with conducting drills on AVB, when you look at even getting a Kiwi and maybe a Mama Badhi and the doll, for us, we work with the sub-counties. We're looking at having one for each sub-county. It's already a huge expense. So I would really love to hear where exactly are we, especially in the 6 counties that we have already rolled out this.
Thank you, a good question. So, as I said earlier, we've trained 6 counties with the support of partners, and we've encouraged counties, as they do their RAMCA budgets, they factor in equipment for EMOC mentorship. At national level, we will, with the support of partners, UNICEF is in place, has given us some equipment. We are going to distribute them to all the ASAL counties. They are normally around 17 counties. And also UNFPA had given us some equipment which are already distributed to KMTCs and some of the county hospitals. But it's our responsibility as at national level to ensure that we equip all the county referral hospitals. But we are encouraging counties to own that mentorship process, have a budget in place. So they've done their budgets already. So it is now up to us. We do a follow-up. We find out how many equipments so far have been purchased. And for example, the ones we trained Vihiga County and Siaya, I normally confuse Siaya and Homa Bay. MCGL has been able to support them in terms of equipment. So Vihiga County, maybe you can tell us. I know you have equipment in place. They are at your Vihiga County Referral Hospital. Is it right?
Okay, for Vihiga County, first of all, we want to appreciate LSTM gave us the first equipments, which we began with, And as we continue, MCGL has also procured some equipments. So we are stocking the level 4 hospitals and the county referral hospitals. We have identified rooms as skills lab. We may not be there, but we are going step by step. And as you said, in our budget, we were able to include, but also there is a lot of advocacy to be done to the members of county assembly, why we really need, because most of the time we do it in our budgets and they tend to reduce them when they are doing, when they are going through. So there is that need, and we have, there's a partner who have come in to support us to do a lot of advocacy on RAMCA, that is Capricorn. So we are going to do that to ensure that our budget is sustained and ensure that we get more equipment to ensure that all the level 4 with the skills lab are working.
Thank you so much, Vihiga County, and I think the same is happening to Siaya County, and also LSTM has really supported the ministry in supporting a training institution, more so KMTCs, and specific counties. So the government does not function on its own. The monies that stakeholders or partners have, the government assumes it is part of its money. So whichever country that you are working in and you have a partner that is supporting RAMCA, please can you put on their desk and tell them these are our priority areas. So if you want to support anything to do with RAMCA, please you have to pay to our annual work plans. They be able to support our budgets in terms of equipping, and also in terms of doing facility mentorship trainings for EMOC. Thank you.
Thank you. I just wanted to add to that. When you're thinking about costs of equipment, whether it's for training or for clinical purposes, you've got to think of the cost of the alternatives. I would put it to you that doing an assisted vaginal birth is a whole lot cheaper than doing a cesarean section. A kiwi, I think, costs about $30, and I think they'll last for probably 10 deliveries. That's $3. How much does it cost you to do a cesarean section? I'm sure it's an awful lot more than $3. So don't just think of it in isolation in terms of the cost of the equipment and can we afford it. Think, can we afford not to purchase it because of the alternative? Because if a woman can't push the baby out, she either needs a vacuum or a cesarean section. There's no other way. So which is cheaper? And if you agree with me that cesarean sections are a whole lot more expensive, then you can't afford not to buy the Kiwis, whether you're national or regional or county governments, really. Thank you.
Just one thing. So of some of us who are coming from counties, I know we have county leadership here. Please, when you are doing those budgets, make sure, Fatuma from Garissa, make sure you have something for EMOC equipment. Thank you so much. And on costing, we haven't costed. We have the skills that, the equipment that have been approved by the ministry together with counties and our stakeholders. We had a meeting for that. So we will be sharing. Whoever would like to have the specific equipment that the ministry has approved, I'll share the list, but we haven't costed. I think we need to cost. Thank you so much.
Thank you very much, everyone. But before we close this session, for the partners who are here and doing trainings online in the counties, kindly liaise with the ministry, because you are training online, skills-based, and there's no demonstration. So I don't know how you are doing them and certifying, giving certificates to nurses or healthcare providers without demonstrations. So kindly liaise with us, because we know you and you have gone to the counties and we have the reports. Kindly liaise with us, because whatever you are doing, sorry, it's not right. Because you cannot do an online training that is skills-based, giving certificates, and there's no demonstration. There are no skills that have been demonstrated online. So kindly liaise with us, and then you can also liaise with us for us to be able to know if you're having a challenge in the county and you want to do a skill-based training, liaise with us for quality purposes, because we have a QOC tool for us to be able to know the trainings that we are doing in the counties are credible and approved by the ministry. I think that one is clear for all of us partners who are here. Thank you very much. Let's appreciate Helen and Helen. Lunchtime, I don't know if the vouchers are, okay, we have vouchers in the room. Kindly pass by as you pick your voucher. We are eating from the same place yesterday. All right, so let's meet exactly 5 minutes to 2 for the afternoon session. Thank you very much, and thank you for listening to all the presentations, and thank you very much for your active participation. Clap for yourselves. Thank you.
My name is Veronica Musiega. I'm a registered nurse, midwife. I work in Vihiga County where I coordinate reproductive health services within the county at county level. I will say that Vihiga really benefited in the FCDO trainings, especially EMOC, where we have been able to train a very, I think over almost even up to 180 healthcare providers on emergency and obstetric care. And we've also been able to train our doctors, our theatre team on advanced emergency care that I think almost up to more than, I will say around more than 10, yes. And following those trainings, I think we've really seen a reduction in maternal mortalities, because initially we used to record 10 above, but following the trainings that we've had, we've really been able to reduce, because I can say for the year 2019, we lost around 8 mothers. The year 2020, we lost around 5 mothers. Then 2021, that is last year, I think we lost, is it about 7? And so far this year again, we have had a further reduction, so that for the financial year 2021-2022, that is July 2021 to June 2022, I think we have lost so far 3 mothers.
LSTM has been supporting Uasin Gishu for quite some time. We've had, I think, more than 8 EMOC trainings. The first trainings were fully funded by LSTM, but I think the last 4 or 5 were partnered between LSTM and the county. And once after the trainings were done, we were able to have a pool of mentors, courtesy of LSTM. And so currently, we are actually able, almost all our facilities do have trained mentors who are able to mentor their colleagues on the various skills in maternal and newborn. And with that, that has actually translated to an increase of skilled birth attendance in Uasin Gishu County, and a reduction in the necessary referrals from the lower facility to the higher facility.
And most of our healthcare providers are now competent enough to provide most of the obstetric emergencies, including emergency resuscitation of the mother. They are able even to use the pathographs very well, and be able to monitor, detect obstructed labor early enough, and even call for ambulance early, or even seek for help early enough. Then quite a number of them, again, are able, when there is postpartum hemorrhage, they have really learnt a lot. They have able to put up IV fluids very fast, and even put up interventions to reduce the bleeding. That is using the Dr. ABC approach. And then even use of the UBT. By the time they even refer our clients to the main referral hospital, you'll find that even a uterine balloon tamponade has been put, and they've really tried very hard to reduce these mortalities. My name is Veronica Musiega. I'm a registered nurse, midwife. I work in Vihiga County where I coordinate reproductive health services within the county at county level. I will say that Vihiga really benefited in the FCDO trainings, especially EMOC, where we have been able to train a very, I think over almost even up to 180 healthcare providers on emergency and obstetric care. And we've also been able to train our doctors, our theatre team on advanced emergency care that I think almost up to more than, I will say around more than 10, yes. And following those trainings, I think we've really seen a reduction in maternal mortalities, because initially we used to record 10 above, but following the trainings that we've had, we've really been able to reduce, because I can say for the year 2019, we lost around 8 mothers. The year 2020, we lost around 5 mothers. Then 2021, that is last year, I think we lost, is it about 7? And so far this year again, we have had a further reduction, so that for the financial year 2021-2022, that is July 2021 to June 2022, I think we have lost so far 3 mothers.
LSTM has been supporting Uasin Gishu for quite some time. We've had, I think, more than 8 EMOC trainings. The first trainings were fully funded by LSTM, but I think the last 4 or 5 were partnered between LSTM and the county. And once after the trainings were done, we were able to have a pool of mentors, courtesy of LSTM. And so currently, we are actually able, almost all our facilities do have